Welcome to Section 7 of the Falcon Physician Review series online. This time we'll be discussing the skeleton and vertebral development. You're already aware of the fact that the skeletal system has approximately 206 bones, which all articulate together with the joints and cartilage in between. You may not be aware of the fact that the axial skeleton, which is including the skull and the hyoid and all of the midline structures such as the vertebrae, which there are 33 of them fusing into 24 presacral mobile ones and a couple of fused postsacral immobile segments, as well as the ribs and the sternum. That totals up 80 bones. But a large component of the bones in the body are appendicular, with over half of the bones coming from the limbs alone, or the hands and feet. The upper limb would be 64 and the lower limb would be 62 bones in total. So let's look at the skeletal development of the skull. The skeletal system is going to be developing from the mesoderm and some of the neural crest cells for components of it. The neural crest cells are going to be migrating into the pharyngeal arches and forming the bones of the craniofacial structures. The neurocranium and the visceral cranium are two components of the skull. The neurocranium has the calvarium, which includes the parietal bones, the frontal bones, the squamous temporal, and part of the occipital bones, which all ossify by intramembranous ossification. The rest of the skull bones, the ethmoid, sphenoid, petrous temporal bones, basioccipit, all ossify by endochondral, which is the cartilaginous model formation. If you look at the visceral cranium, which has been highlighted here, the visceral cranium essentially makes up the facial component, whereas the neurocranium makes up the components that would house the brain. Of the visceral cranium, the mandible, maxilla, zygomatic bones, palatine, vomer, nasal, and lacrimal bones will all be intramembranous formation, whereas the three bones or the ossicles of the ear, malleus, incus, and stapes, as well as a styloid process and hyoid, will form by endochondral bone formation. And it's the components of the face that largely get the neural crest development. So, as a key point in any of the questions you're doing in the USMLE prep or on the test itself, remember that when there are skeletal malformations of the skull, especially the face, this oftentimes points us to the fact that there's been a migratory problem with neural crest cells, and you can oftentimes see other things that are problematic, such as cardiac development, autonomic developments that are going to be tied into that question. So keep your eyes peeled for that as an important red flag. Let's look at the formation of the skull in the newborn versus the adult. Notice how the newborn does not have a visceral cranium because it has not grown yet, but the neurocranium is well formed in that it's large compared to the rest of it. And that's what gives children their little round Charlie Brown heads that we're all so attracted to, it seems. If you look at the fontanelles, those are important overlap points that will be allowing the skull to pass through the female reproductive tract during parturition. The fontanelles, the important thing that you need to remember about them is that their closing times tend to be in the rule of threes, or in this case sixes, where the anterolateral and posterior laterals will tend to close up around 3 months. The posterior fontanelle will close anywhere from 3 to 6 months, and the anterior fontanelle will close anywhere from 18 to 24 months. And there's the reference points, bregma, lambda, pterion, and asteron are reference points that you should be familiar with. Of particular importance, we'll discuss the pterion because of its clinical significance. Looking at abnormal skull development, you have the dysraphic conditions, which is a whole subset of closure problems of the vertebral canal. Here we can see the cranioschisis, which is a failure of the cranial closure. Remember, we said earlier that schisis tends to be a very bad outcome, and they tend to be the worst of the formative problems. Anencephaly, which is a formation or no formation of brain, and that's oftentimes because the bones overlying the brain are not there, therefore the inductions were not proper and it was exposed to too much environmental trauma and never really forms. Acrania is no skull. Craniosynostoses are early sutural closure problems, and there's a whole subset of those, a couple of which you should be familiar with. First of all, there's scaphocephaly, which is an early closure of the sagittal suture. Notice how in this child it gives a elevated forehead look to the child in an oblong skull. Acrocephaly is the closure of the coronal suture, which kind of gives a keel-based progression or protrusion of the frontal bone. And then trigonocephaly, which will oftentimes be an early metopic suture closure. Now, the metopic suture is something you need to be aware of for testing in a couple senses. One is that the metopic suture is the two sides of the frontal bone which normally fuse together. However, if it happens too early, you'll start to get a narrow, pointy edge to the frontal bone in a child. Going down further and looking at vertebral development, we're going to look at some of the sclerotome cells that will be displaced medially from the ventromedial part of the somite and how they fuse together to form this very complex side of the vertebral canal, which has many components contributing to it. And the reason that you'd want to have a general idea of these components is because there can be different problems with different components. The sclerotome cells are going to move medially and form what's known as the perinotochordal sheath. And then the lateral sclerotome, the mesenchyme, will arrange into some loose components, which will be cranial, and some dense components, which will be the caudal portions. This perinotochordal sheath will also arrange into the same idea with loose and dense areas. However, there'll be an overlap between where these are. If we look at the diagrams below, at 28 days, there's a rather amorphous organization of the mesenchyme. Then the mesenchyme will start to move the sclerotomal cells medially, and you can now see that there's a separation between the perinotochordal sheath and the sclerotome. How the blue and red will break down the loose and the dense components of those in the sclerotome, and then in the 33-day picture you can see that same dense-loose connection that's happening at the perinotochordal sheath. Finally, in the last component, you can see how the nerves are starting to grow in there with vessels, and they're alongside the somites, and this is at about week 5 or 6. When we move to the next level, you can see that the sclerotome and the vertebral units will come from these various different components of the vertebral forming scleromyotome. First off is the centrum, which is the body of the vertebral body. The centrum will be formed from the loose parts of the perinotochordal sheath from two adjacent somite levels. Here you can see the centrum being formed by the two adjacent perinotochordal levels. Second forming is going to be the intervertebral disc, and the intervertebral disc will come from the compact portions of the perinotochordal sheath. So they'll sit in between the centrums. And then finally the neural arch, which will be formed by the compact parts of the sclerotome more laterally. And here you can see how those neural arch components will contribute on bilateral aspects to form that complete neural arch. So the complexity that you see in any type of body formation will also be an indication of the many things that can start to go wrong with it. So if you have more complexity of formation, you have more opportunities for malformation. Let's talk about some of the common things that are tested on USMLE. The closure problems of the vertebral canal will lead to different types of spina bifida. There are 4 types that you need to be well aware of. The first and simplest of these, which is the most correctable, is the spina bifida occulta. The other types are known as spina bifida cystica, and there are 3 subcomponents of those. Remember that occulta is oftentimes more caudally located and will oftentimes only have the indication on the skin of the sacral or lumbar regions where there's a tuft of hair that exists. What happens with the occulta is that the spinal cord and the thecal sac are all within the vertebral canal, but the vertebral canal is not completed dorsally. With the cystica components, there is a cystocele in the thecal sac. With the meningocele, there's a lot of cerebrospinal fluid that is protruding from and out from the skin, but the vertebral column has no posterior neural arch formation portions, which has allowed this to happen. The important thing to know about the meningocele is that the spinal cord is still within the spinal canal. Therefore, these are fairly repairable, and children will still oftentimes have full function of their limbs. The more serious it gets, the longer the name gets. So we have a meningomyelocele, and the meningomyelocele is different from the meningocele, and it's worse because the spinal cord has left the vertebral canal protection and has protruded out into the cystocele that's been made because of the lack of the vertebral arch to contain it. These children oftentimes have spinal cord injuries, or their spinal cord is injured at the time of birth. The worst one, of course, is the schisis. Myeloschisis is the incomplete closure of the thecal sac, which exposes the neural tube and the neural development of the spinal cord to the amniotic fluid, and these children are always paralyzed beyond the point of the failure of closure. Here is a question. An infant seen here was brought to your attention during rounds. The attending asked you to diagnose the infant and explain your findings to the parents. Based on the physical findings that the infant was able to wiggle its legs and arms, what would you suggest as the likely diagnosis? And this one has a couple possibilities. You can see a cyst that's protruding, so it is not an occulta. You can see that there is fairly plump leg musculature in this infant, so this would be an enclosed cystocele, so it's either a meningocele or a meningomyelocele. It cannot be a myeloschisis, and it's not an anencephaly because the cranial vault is intact. The difference to tell one from the other in this particular question is that the child is able to wiggle its legs, which would mean that the child is more likely to have a meningocele than the myelomeningocele. That concludes our portion on the skeleton and the vertebral development. In the next segment, we'll discuss the regions and the curvatures of the spine and their clinical significance.